Hello everybody, my name is Dr. Thomas Deering from Piedmont Heart Institute in Atlanta, Georgia. And I'm pleased to have with me today as my guest Dr. Mintu Turakhia from Stanford University. He's an assistant professor of medicine in the Department of Cardiology, Electrophysiology, and he also serves as co-director for the Digital Health Initiative for Stanford University. And that's the topic upon which we're going to focus today. We're here at Napa for the annual Piedmont Stanford Cleveland Clinic Conference and have a great opportunity to explore with Dr. Turakhia some of these options. Mintu, thank you for joining me here today.
Thank you, Tom. Pleasure to be here.
Glad to have you. We're in an evolution in the way in which healthcare is delivered. We're moving from the volume to the value curve, and we're really taking more ownership of the whole patient process. In your field, you're doing a lot of work in this direction. You live in Palo Alto, the IT capital of at least North America, maybe the universe. What are you doing in this field? What do you see as the major initiatives that can help us address these new evolutions in the delivery of healthcare in our population?
Yeah, so it's a really exciting time, and I'm glad you're asking this question. We've had an explosion in tech, and as kind of traditional tech establishment has moved into healthcare, we first saw an explosion of sensors and technologies to get into the retail space. But the key underpinnings of why this is now affecting us and how this is actually maturing to not just be a niche wellness product or device or framework is changes in healthcare payment reform. So when you look at value-based care, as you said, and these new alternative models, we as clinicians and the healthcare systems are heavily incentivized to keep patients well, keep them out of the hospital, and keep them healthy. So how do you do that in ways beyond just having a patient visit you or your advanced practitioner frequently? And that's really the crux of the matter. And the technologies, the new delivery models, the care platforms are all seeking to do that.
One of the key important parts is building those particular steps that make the whole package, really valuable. Engaging the patient is important. How do you do that? What have you worked to get the patients involved?
Yeah, so it's a great point. And if you look at the world of devices that are available, and we'll focus on cardiology, you can have an ECG-based smartphone monitor so patients can measure their own rhythm. You can have wearable long-term ECG monitors that we might prescribe that are miniaturized, all the way to phones and apps that measure medication adherence, track movement, look at activity, and then of course, the wearable activity bands and sensors that people may use. So when you look at these tools in isolation, they don't work. Eric Topol had a study called the Wire for Health study that tried to use these tools. They gave patients, or randomized them to a connected blood pressure cuff, a iPhone-based glucose monitor, and the AliveCore ECG device, and said, here you go. The problem is it didn't work, and the reason it didn't improve utilization or any patient measures of engagement was that these things just don't work on their own. You can't just prescribe an app. So what we've done at Stanford is a couple things. On the clinical side of our enterprise, we have a same-day visit program and an urgent care visit program called ClickWell, which in addition to your continuity care, you can get a virtual visit on the same day. And that can be through a simple telephone or a video chat through a smartphone or a desktop computer, you name it. Now, the providers will interact with you in the doctor-patient relationship, but in addition, we again realize on the clinical side, you need to have coaching and care teams, and that whole framework has been set up. And we have also replicated that in parallel fashion for many of the randomized trials we do.
And that's a very important part. So you've got the patient, and you're right, all the data suggests that if we just leave the patient alone and we don't educate and engage them, that doesn't work. So you have an entire team of people so that you can, when they have issues that are concerning to them, or they have, metrics that have, gone above the boundary, they can engage the team rather than going to the ER or rather than having it protract in time and something bad develops.
That's exactly right. And so I would say there's a couple of things that we've learned here. The first learning really comes from our field in electrophysiology, where this whole issue of remote monitoring has been there a long time. Patients have home remote monitoring devices for their implanted pacemakers, their defibrillators. We get the data, we get paid and reimbursed to look at it, It's in a cloud. It's in a way that's easily interchangeable. And all of the studies thus far have shown that remote monitoring is associated with every favorable outcome you can imagine, including mortality. And it's not like the remote monitoring device is emitting some magic frequency that heals the patient. It's more that the process of getting the data, looking at it, seeing the AFib, getting the anticoagulation done early, managing all their other problems when you call them, is most likely what is happening here. Now, fortunately, Medicare and other payers see that model as something that should occur even if you don't have an implanted device. And that's where this new chronic care reimbursement telehealth codes are coming, so that if you are a provider and you're caring for a patient with more than one chronic condition, as long as anyone in your office, down to a medical assistant, up all the way to the clinician, spends 20 minutes or more, you get a reimbursement. So the idea is to incentivize physicians and practices to offer basic communication in a way that rewards them, and again, as you say, Tom, keeps patients out of the ER and urgent care.
And by having those three components there, the patient who takes ownership of his or her own health care is always important. But then you have your team that's available. But I assume, just like we do with our cardiac implantable electronic devices, we have, barriers high and low for things that we need notification upon. So if someone has new onset AFib or AFib at a more rapid rate, so we can control the rate, or initiating anticoagulant therapy. So you've got processes, I assume, in place so that if people hit those particular boundaries or those particular levels, you can intervene at an earlier stage where theoretically and hopefully, there is less, negative outcome.
Yeah, so that's a really important point. And I think one of the concerns that the community of clinicians and hospitals have is this data deluge problem. What do you do in an avalanche of data? What is the accountability? What is the liability? What if I miss something? The entire issue in my mind, I think, is because of a deep flaw in the way we've been thinking about this. So even with remote monitoring data, the patient has to take it upon good faith that the data came off their device and went to the cloud of the manufacturer and then went back down to his or her designated provider. And then they looked at it. The patient actually has no feedback to even know if the data was really looked at. Mm-hmm. So the problem here is you have this opaqueness in the patient not getting their data and then not having the means to even know if it was looked at. I think the issue really would be more easily solved if we gave patients the data. So it's okay if a patient sees that they have new AFib. It's okay if they're told that there's an impedance alert. It's okay if other non-invasive sensors do the same thing. They can go out and buy, a patient with a pacemaker, go out and buy a watch band that will tell them the things that they're not able to unlock on their device. So we have to really rethink the patient's relationship with the data and let them be empowered. And if you empower the patient to be the first responder, that would solve many of these problems.
I think that's a very important key point, because at one end you have the institution that if we see this that is problematic, we will deal with it. But you have the patient doing the same thing. And then I assume you have set up, like you talked about with your clinic, your teleclinic, mechanisms for that communication to occur at a time that is collectively convenient as opposed to emergent, et
Yeah,
cetera.
and that is going to be an evolution. So for example, with ClickWell, patients do have the ability to upload their data. What they lack, until there's uniformity across all EMRs, is going to be an ability for them to curate the data. So right now, if a patient wants their Stanford medical records and their Piedmont Heart medical records, they can get a disk or a PDF or printouts, but it's all static. It's a catalog. Mm-hmm. It's a log of data. Right. And if I'm a snowbird and I split my time between two healthcare regions, I don't get to do this with my data. Whereas if you look on the retail side, there is software that can take your transactions from one credit card, another bank, a stock portfolio, even your frequent flyer miles, put it all together so you can see that. That's really the next step in how this data is integrated and aggregated for patients to react on first.
No, I think you're right. We're kind of, even though we're electronic in our medical records, we're kind of in the old paper thing where the bank would send you the bill and the, power company would send you the bill, but we can get on our cell phones and get everything we want. So how do you see this technology evolving so that we have pure interface with the, digital mechanism or the digital approach that the care teams need and the patients want?
So, great question. And I think, there probably is not going to be a better way to do it than to have the patients manage the data and actually broker what goes back to all their other providers. And this is a bit humbling in where we are. So we are really, as in healthcare, have to start thinking of ourselves as service providers at some level on parity with lawyers and accountants and other people, that when patients or customers use them, control the flow of information that they get. A lawyer only gets what the patient gives them if they're or the client gives them if they're representing them. This is going to be no different, right? So your CPA, your accountant gets all of your statements, and if you don't give them something or they don't have the control to get it, it's not going to be on your return. It's going to have to be the same way. And the reason for that is healthcare no longer happens in one place. Healthcare may happen in a healthcare system for most things, but the urgent care visit, if somebody's traveling, may not be at that center. We are seeing now in the service-based model that that's developed in Northern California, much like Uber, you can hail a taxi or a car with your phone. You can actually hail healthcare with your phone too. Docs can come see you for same-day visits. You can get specific prescriptions that you need. Mail-order prescription business is big. So at some point, all of this needs to converge, and the only place it can converge is going to be the patient, who then pushes it back to their providers.
It's an exciting movement that is developing, and I think it clearly represents an important part of healthcare evolution. You guys are on the cutting edge in this. What has been your initial first pass experience on this, Mintu?
I think it's a learning process, and there's a couple sides of that. One is that the tech venture community, that now healthcare is sort of the darling of where it's sort of the next big thing that can be disrupted, where there's a lot of inefficiency, therefore there's a lot of opportunity to make money. That may very well be true. But this idea of making things and trying to monetize them quickly without evidence is a problem. I mean, look at Theranos and what's happened. So what I think is happening now is there's greater alignment between the inventors, the entrepreneurs, the investors, the hospitals, and the clinicians, that you gotta bring these things in slowly. You have to get stakeholder buy-in. You do need to test them rigorously. And you also need to get the patient's input as to, what do you think of this? Is this gonna work? So we have patients involved in design, experience, focus group, feedback, and we also do that in our studies as well, which is again this whole idea of engagement and having patient-centered design.
That's great. It's wonderful to hear what you're doing. You've got the 4 parts of the stool. You've got the engaged, involved, interested patient who is helping to direct how this goes in conjunction with the engineers and the entrepreneurs and the clinicians who drive it. And then you've got the team put together to figure out how they're going to work with them and the processes so that everybody communicates about how they're going to interact. And then the appropriate reimbursement at penalty level, at reward level, or at coding level while we move from volume to value in the new arena. So this is an exciting time. I'm sure we'll hear more about you and what your team is doing over time. And thank you for spending the few minutes recently with me.
Tom, thank you. It was a real pleasure to chat.
Thank you again very much. Thank you.